Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the cardiology, that is the aortic stenosis. So first let me take up what exactly is the definition of the aortic stenosis. In aortic stenosis, the valve area of the aortic valve, it will be narrowed. That is what is your aortic stenosis. And because of this narrowing of the valve, there will be increase in the gradient between the left ventricle and as well as the aorta. So, in patients with aortic stenosis, what exactly happens, or it is defined as the obstruction to outflow from the left ventricle, right? It is defined as obstruction to outflow at the left ventricle, and this obstruction, it is at or near the aortic valve, right? This particular obstruction, it is present at or near the aortic valve. So that is what is your aortic stenosis. So you can observe that here. So this is the left ventricle and this will be the aorta. So what is happening here? There is an obstruction to the outflow. Okay. So because of obstruction to the outflow at the left ventricle, exactly at or near the aortic valve, this will produce a systolic gradient. Because of this obstruction, there will be a systolic gradient, and this particular systolic gradient, whichever is produced, it will be more than 10 millimeters of mercury, right? It will be more than 10 millimeters of mercury between the left ventricle and as well as the aorta. So if you take the normal gradient, right, normal gradient is around 5 millimeters of mercury, but here the gradient which is being created between the left ventricle and aorta due to the obstruction to the outflow will be more than 10 millimeters of mercury. So that is what exactly is the definition of the aortic stenosis. And the next question is, aortic stenosis is called severe when aortic valve area is less than 1.5 centimeter square, less than 1 centimeter square, less than 0.5, less than 0.2 centimeter square. Now, if you take the severity of the aortic stenosis, so severity of the aortic stenosis, right, based on the valve area. Right, based on the valve area. So we classify this into mild, moderate, and as well as severe aortic stenosis. So in case of the mild aortic stenosis, the valve area, so first of all you need to know how much is the normal valve area. Normal aortic valve area is around 3 to 4 centimeter square, right? So in case of mild aortic stenosis, the valve area will be in between 1.5 to 2 centimeter square, whereas in case of the moderate aortic stenosis, the valve area is in between 1 to 1.5 centimeter square, whereas in case of severe aortic stenosis, the valve area will be less than 1 centimeter square. Okay, so this is how we assess the severity of the aortic stenosis: mild, moderate, and as well as severe. In mild, it is 1.5 to 2, moderate 1 to 1.5, whereas in severe, it is less than 1 centimeter square. So the question is, aortic stenosis is called severe when the aortic valve area, it is less than 1 centimeter square. Now, coming to the etiology of the aortic stenosis. So we have many etiologies causing aortic stenosis, out of which the two common clinical scenarios in which aortic stenosis is prevalent is the following. Now, we classify the etiology in the way according to the age group. like in young individuals, the etiology of aortic stenosis is different from the etiology of aortic stenosis in elderly individuals. Okay, so now the first one, like in the age group less than 60 years, right? In age group less than 60 years, the most common cause of the aortic stenosis will be unicuspid or the bicuspid valve. Okay, so it will be congenital aortic valve stenosis, right? It will be congenital aortic valve stenosis. And this congenital aortic valve stenosis, it is either unicuspid or, right, unicuspid or bicuspid valve aortic stenosis. So if you take the normal aortic valve, right, normal aortic valve, it is tricuspid, right? The normal aortic valve, it is tricuspid, right, which is a semilunar valve. But in case of congenital aortic valve stenosis, the valve either it is a unicuspid valve or it is a bicuspid valve. Okay, now, and the age group, what did I say you? The symptoms can occur in young or adolescent individuals if the stenosis is very severe, right? If the stenosis, if it is severe, then there will be development of the clinical features of the aortic stenosis. Okay, and what is the age group I said? Like less than 60 years of age, right? Whereas you take the other important etiology causing aortic stenosis. And one more point what I want to tell you is, because this is a congenital cause, either unicuspid or a bicuspid aortic valve. And in these patients with the congenital aortic stenosis, one more congenital abnormality is associated, and that is nothing but the coarctation of aorta. So the another congenital abnormality is, right, another important congenital abnormality that is seen in associated with congenital aortic stenosis will be the coarctation of aorta. Okay, and next important point, please remember, offspring of a patient with bicuspid aortic valve have much higher incidence of the disease in either the valve, the aorta, or both. Okay, so what I want to tell you is, offspring with a bicuspid aortic valve, they have much higher incidence of the disease either in the valve or in the aorta or both. Okay, so that is about the etiology of aortic stenosis in individuals age group less than 60 years. Most commonly it is congenital aortic stenosis. Whereas you take in elderly individuals, right? In elderly individuals, in the sense, in individuals more than 60 years, the most common cause for aortic stenosis will be degenerative or calcific aortic stenosis. Okay, in young individuals or in adolescents or in individuals less than 60 years, it is congenital aortic stenosis. But the most common pathological process, that is degenerative or calcific aortic stenosis, is thought to be related to calcium deposition. So what exactly happens here in calcific aortic stenosis? Right, it is the calcium deposition within the valve. Okay, so this calcium deposition, it is almost similar to those that occur in case of atherosclerotic vascular diseases. Okay, now if you see the distribution of the age group also, in individuals around 65 years, the chances of your degenerative or calcific aortic stenosis will be approximately 25%, whereas in those individuals of age group 70 years, right, in those individuals of age group 70 years, the incidence of the degenerative or calcific aortic stenosis will be around 35%. Okay, so in elderly individuals, the most common cause will be degenerative or calcific aortic stenosis. Okay, and what is this called as? The sclerosis of the aortic valve. So here what happens is, there will be aortic valve thickening. Right, and this aortic valve thickening, we call this as sclerosis of the aortic valve, right? Now, almost like 10 to 20% of these will progress to hemodynamically significant aortic stenosis over a period of 10 to 15 years. So, these individuals with degenerative or calcific aortic stenosis over a period of, right, over a period of 10 to 15 years, right, they will progress to hemodynamically significant severe aortic stenosis. Okay, so that is about degenerative or calcific aortic stenosis. Next, now apart from this, so one important etiology what we have discussed is congenital aortic stenosis, and second important etiology degenerative or calcific aortic stenosis. And apart from that, certain genetic markers are associated with the aortic stenosis. This is a very important multiple choice question, right? So what is the genetic marker, right? What is the genetic marker which is associated with aortic stenosis? And this particular genetic marker, it is most notably notch 1. This is a very important question, right? Most notably it is notch 1. So certain genetic markers are associated with aortic stenosis, most notably notch 1, right? A genetic component appears a likely contributor at least in some patients. So in those individuals who is having a genetic marker of notch 1, they have the tendency of development of your aortic stenosis. Now, apart from the congenital aortic stenosis and as well as calcific or degenerative aortic stenosis, the other etiologies which will cause the aortic stenosis will be rheumatic heart disease. But regarding the rheumatic heart disease, let me tell you one of the very important point. See, rheumatic valvular disease is that, like in rheumatic heart disease, definitely yes, there can be development of the aortic stenosis, and if the aortic valve is affected by the rheumatic fever, concomitantly mitral valve is also invariably affected. Okay, so in these individuals where there is involvement of the aortic valve, invariably there is involvement of the mitral valve as well, right? Invariably there is involvement of the mitral valve as well. Okay, so that is about the etiologies of the aortic stenosis. Then what are the risk factors for aortic stenosis? See, aortic stenosis has become the most common surgical valve lesions in developed countries, and many patients are elderly individuals. And if you take the risk factors for aortic stenosis, that includes number 1, the presence of the hypertension. Next, the second important risk factor is hypercholesterolemia. And the third important risk factor is smoking. So these are the risk factors for the development of the aortic stenosis. Okay, and these patients with the aortic stenosis, they also have a coexisting cardiac disease, and that particular coexisting cardiac disease will be hypertrophic cardiomyopathy. Right, hypertrophic cardiomyopathy. So this is the coexisting cardiac disease which can be seen in association with the aortic stenosis. Now, after having discussed about the etiology and as well as the risk factors, let me discuss the pathophysiology of the aortic stenosis. Now, we have a terminology called mild aortic stenosis. So in case of these patients with mild aortic stenosis, the gradient is around 20 millimeters of mercury. Now let me discuss what exactly is this. See, when aortic valve becomes stenotic, it creates a pressure gradient between the left ventricle and aorta. So when there is aortic stenosis, that creates a gradient, right? That creates a gradient between the left ventricle and as well as aorta. Okay, and the more constricted the valve, the higher is the gradient between the left ventricle and aorta. Like for instance, you take in patients with mild aortic stenosis, right? You take in patients with mild aortic stenosis, the gradient may be 20 millimeters of mercury. Now what does that mean? This means that at peak systole, right? That means that at peak systole, right? At peak systole, while the left ventricle may generate a pressure of 140 millimeters of mercury, right? Left ventricle will generate a pressure of 140 millimeters of mercury, but the pressure, right? But the pressure that is transmitted to aorta, right? But the pressure that is transmitted to the aorta will be only 120 millimeters of mercury, right? Will be only 120 millimeters of mercury. That is what is your mild aortic stenosis. Okay, so the meaning of the word gradient 20 millimeters of mercury means the left ventricle will generate a pressure of 140 millimeters of mercury and the pressure that is transmitted to the aorta will be 120. And where is the 20 going? Because of the obstruction at the level of left ventricular outflow tract, the pressure which is transmitted to the aorta is only 120 millimeters of mercury. Now, what will be the consequence of this? The consequence of this is development of the left ventricular hypertrophy. And what type of left ventricular hypertrophy? It is concentric left ventricular hypertrophy. So you please understand here, while the pressure, that is the blood pressure in aorta, may be 120 millimeters of mercury, but the actual pressure within the ventricle is much more than that, right? That is 120 in the aorta and in the ventricle it is 140. Now the increased pressure that the left ventricle has to generate to increase the blood flow to the aorta results in the left ventricular hypertrophy, right? So it is 120 in the aorta. Now what the left ventricle will try to do? Left ventricle will also try to generate the increase in blood flow to the aorta, and it will ensure that even the aortic pressure also will reach up to 140, and in that particular event the left ventricle, it undergoes hypertrophy, right? And what type of hypertrophy is that? That is concentric hypertrophy. Okay, so now we have one more type of hypertrophy called eccentric hypertrophy. Eccentric hypertrophy of the heart. This is seen in patients with the aortic regurgitation and as well as the mitral regurgitation. So in aortic regurgitation and mitral regurgitation, what you will have is eccentric hypertrophy, whereas in aortic stenosis, what you will have is the concentric hypertrophy. What is the difference between these two? See, in case of the concentric hypertrophy, there is no cardiomegaly, right? There is no cardiomegaly, but there is increase in thickness, right? Increase in the thickness of the left ventricular wall. That is what will happen in case of the concentric hypertrophy. But whereas in case of eccentric hypertrophy, there is cardiomegaly, right? In case of eccentric hypertrophy, there is cardiomegaly. Okay, there will be increase in the size of the heart, or there will be increase in the cardiothoracic ratio in the chest X-ray, where in case of the eccentric hypertrophy, right? Now let me just discuss the hemodynamics in detail. So if you see the hemodynamics, in patients with aortic stenosis, there will be obstruction in flow of blood through the aortic valve during ventricular systole. So whenever the ventricle is undergoing the systole, there will be obstruction in the flow of blood, and because of that there will be ejection systolic murmur, right? Because left ventricle is trying to push the blood into the aorta, but there is an obstruction at the level of the aortic valve, and that will give rise to an ejection systolic murmur. And because there is obstruction in the flow of blood, there will be symptoms due to reduced cardiac output. And what will be that symptoms due to reduced cardiac output? That includes syncopal attack, angina, and as well as the dyspnea. This will be the symptoms due to reduced cardiac output. Now, the obstruction is overcome by rising the systolic pressure of the ventricle. And because of powerful muscular left ventricle, the emptying of the left ventricle is complete, but the duration is prolonged. Right? Left ventricle is trying to overcome that obstruction by powerful muscular contraction. So, the emptying of the left ventricle will occur, but the duration is prolonged. And thereby what will happen to your A2? A2 will be delayed, right? And this prolonged ejection, whatever is there, so the ejection into the aorta from the left ventricle is not occurring in a normal time. It is occurring in a longer time. So that is what is called as the prolonged ejection. So this prolonged ejection causes a characteristic pulse which can be described as a slow rising to peak, right? A slow rising to peak, and that is called as the pulsus parvus et tardus. That is called as pulsus parvus et tardus. So because of this powerful muscle contraction, there will be development of the concentric hypertrophy of the left ventricle, right? Because of this powerful muscle contraction, there will be concentric hypertrophy of the left ventricle, okay? And yes, and therefore in severe aortic stenosis, there is increase in the diastolic ventricular pressure due to excessive hypertrophy of the left ventricle, right? In severe aortic stenosis, there is increase in diastolic ventricular pressure due to excessive hypertrophy of the left ventricle, okay? And in severe aortic stenosis, this we have discussed. With increase in left ventricular diastolic pressure, subsequently there will be increase in the left atrial pressure. So what will happen is there will be increase in left ventricular end diastolic pressure, right? Why? Because the left ventricle is unable to empty the blood into the aorta when there is severe aortic stenosis. Complete emptying is not taking place in severe aortic stenosis. So at the end of diastole in the left ventricle, you have the blood which is coming from the left atrium and as well as the remaining blood within the left ventricle because of inadequate emptying into the aorta. So thereby what will happen to your left ventricular end diastolic pressure? Increases. So when there is increase in left ventricular diastolic pressure, subsequently what will happen to your left atrial pressure? Even the left atrial pressure also will increase, right? Even the left atrial pressure also will increase. So left atria, it has to undergo or it does a forceful atrial contraction, right? Left atria, it does a very forceful atrial contraction to push the blood into the ventricle, right? So because of forceful atrial contraction, that will result in the fourth heart sound, right? That will result in fourth heart sound. So this will be the hemodynamics of the aortic stenosis. So because of an obstruction in the flow of blood through the aortic valve during ventricular systole, there is ejection systolic murmur and there is prolonged time required, or the emptying of the left ventricle, it is taking more time, right? The duration is prolonged and that will result in the delayed A2 and there will be a slow rising pulse with a delayed peaking and that will result in what is called as pulsus parvus et tardus, and the force with which the left ventricle has to contract is more and that will result in the left ventricular hypertrophy, that is concentric left ventricular hypertrophy. Then followed by that, subsequently there will be increase in left ventricular end diastolic pressure and due to which there will be increase in left atrial pressure and there will be forceful left atrial contraction resulting in the fourth heart sound. Okay, so this is about the hemodynamics. Now coming to the symptoms. So we have three important symptomatologies in aortic stenosis. So please remember the mnemonic, that is SAD. The word S stands for syncopal attack. Right? A stands for angina. D stands for dyspnea. Okay, so these are the symptoms of the aortic stenosis, and in those individuals who have the symptoms of aortic stenosis, they indicate worst prognosis. Right, they indicate worst prognosis. So syncopal attack, angina, and as well as dyspnea. So more symptoms indicate the worst prognosis. Okay, now let me take up the individual clinical manifestation in detail. Now, why does this individual develop the dyspnea? Why does this individual develop the dyspnea? So, right, you take this congestive heart failure. So, congestive heart failure in the setting of aortic stenosis, it is due to combination of systolic and diastolic dysfunction. Okay, so congestive heart failure in the setting of aortic stenosis, it is due to combination of systolic and diastolic dysfunction. Okay, it is due to combination of systolic and as well as diastolic dysfunction. Now, why do we consider systolic dysfunction? Because at one point of time there will be reduced ejection fraction. See, what happens is initially it will be diastolic dysfunction only, right? Initially it will be diastolic dysfunction. Now, why is that initially? Why are you considering it as diastolic dysfunction initially? Because there is concentric hypertrophy of the left ventricle. So left ventricle is unable to relax completely. So thereby there will be increase in your left ventricular and diastolic pressure, increase in left atrial pressure. And as the severity further progresses, the diastolic dysfunction will further progress to systolic dysfunction. So there will be reduced ejection fraction in patients with aortic stenosis once there is development of systolic dysfunction. Okay, and you take diastolic dysfunction, right? So how can you tell that there is a diastolic dysfunction? That is by increase in the left ventricular and diastolic pressure. Now, subsequent to this particular systolic dysfunction or diastolic dysfunction, there is increase in, so both of these, right, both of these will cause increase in the pulmonary capillary wedge pressure. And because of increase in pulmonary capillary wedge pressure, there is development of pulmonary edema. And that is what is responsible for dyspnea. Right, that is what is responsible for dyspnea. So that is about the congestive heart failure, why it will be there in patients with aortic stenosis. Then in these individuals, they also have the syncopal attack, right? Now, why do they have this syncopal attack? Most probably or most commonly, this syncopal attack, it is seen in patients with the severe aortic stenosis. So in severe aortic stenosis, there is fixed cardiac output. Right, there is fixed cardiac output in severe aortic stenosis. Okay, now why should they have the syncopal attack? Let me explain you the mechanism. For suppose an individual with severe aortic stenosis is doing the exercise, right? An individual with severe aortic stenosis, if this individual is doing the exercise, what will happen to the peripheral resistance at the blood vessels of skeletal muscles? The peripheral resistance decreases at the blood vessels of the skeletal muscles. Right, the peripheral resistance decreases at the blood vessels of the skeletal muscles. So as the peripheral resistance decreases, what will happen? The blood vessels, they get dilated. Right, the blood vessels, they get dilated. So once the blood vessels are dilated, what will happen to the blood requirement to the muscles? So once the skeletal muscles blood vessels are dilated, there will be increased blood flow to the skeletal muscles. right, there will be increased blood flow to the skeletal muscles. Okay, so once there is increased blood flow to the skeletal muscles, what should happen to your cardiac output? See, the cardiac output should increase, right, and this cardiac output will be increased as a compensatory mechanism. Right, the cardiac output has to increase as a part of your compensatory mechanism. So in a normal individual, this decrease in peripheral resistance, right, this decrease in peripheral resistance is normally compensated by increase in cardiac output. But in patients with severe aortic stenosis, what will happen? In patients with severe aortic stenosis, they cannot increase their cardiac output. Right, they cannot increase their cardiac output. So the blood pressure falls and syncopal attack occurs. Okay, so in patients with severe aortic stenosis, there is the fixed cardiac output, right, and because of this particular fixed cardiac output, the blood pressure falls. Right, the blood pressure falls, and then there will be development of the syncopal attack. Right, there will be development of syncopal attack because of fixed cardiac output. Okay, so that is the mechanism why there will be syncopal attack in patients with aortic stenosis. Next, coming to the angina. See, why does the angina occurs? See, in patients with aortic stenosis, right, in patients with aortic stenosis, there is concentric left ventricular hypertrophy. Right, there is concentric left ventricular hypertrophy. So, once there is concentric left ventricular hypertrophy, what will happen to your myocardial oxygen demand? There is increase in there is increase in the myocardial oxygen demand. Okay, so once there is increase in myocardial oxygen demand, your left ventricle should be in a position to supply that increased myocardial oxygen demand. But in patients with aortic stenosis, right, but in patients with severe aortic stenosis, what will happen to the blood supply to the myocardium? The blood supply, the cardiac output is reduced. So, blood supply to the myocardium is reduced. Once the blood supply to the myocardium is reduced, the muscle will suffer with ischemia. Right, the muscle will suffer with ischemia. Okay, and because of this ischemia, the individual will have angina. Right, because of this particular ischemia, the individual will have angina. Okay, so that is about the mechanism how the angina develops in patients with the aortic stenosis. Now, so these three are the symptoms: syncopal attack, angina, and as well as dyspnea. And dyspnea will occur secondary to your congestive cardiac failure. Now, on examination, what is that you will observe in patients with aortic stenosis? See, first if you take the examination of the pulse. So, you have a characteristic pulse, and that characteristic pulse, it is called Pulsus parvus et tardus. Right, Pulsus parvus et tardus. So, what do you understand by this word Pulsus parvus et tardus? It is a slow rising pulse right, it is a slow rising pulse with late peaking. Okay, so that is what is called as the pulsus parvus et tardus. I'll show you the image also of the pulsus parvus et tardus. And when you palpate the carotid artery, you will feel the carotid thrill. Right, you will feel for the carotid thrill. So what is this particular thrill? Thrill is nothing but it is a palpable murmur. Right, palpable murmur is called as the carotid thrill. Then apart from that, you take the systolic blood pressure. So systolic blood pressure will be reduced in patients with severe aortic stenosis. okay, because the cardiac output is reduced. So that is the reason why the systolic blood pressure will be reduced. So that is about your the general physical examination, pulse, carotid thrill, and as well as the systolic blood pressure. Then you take the systemic examination. Systemic examination, very important, is on auscultation. Right, very important is on the auscultation. So if you take the auscultation, first heart sound is more or less normal, it doesn't get affected, but you take the second heart sound, the intensity of, right, the intensity of the A2 will be reduced. So there will be soft A2, right, there will be a soft A2. And next important auscultatory finding is there will be an additional sound. Apart from S1 and S2, there will be also an additional sound. And that additional sound is the presence of the S4 gallop. Right, it is the presence of the S4 gallop. And S4 gallop, you know, it is a diastolic sound. Right, it is a diastolic sound, okay, which occurs in the later part of the diastole. And next important thing is you will also listen an additional systolic sound, that is aortic ejection click. Right, aortic ejection click. So why is this aortic ejection click being heard? This aortic ejection click is being heard because of opening of, right, opening of stenosed aortic valve. Right, because of opening of stenosed aortic valve, that will result in the auscultation of an additional sound, that is aortic ejection click. Okay, then followed by that the murmur. Murmur is also very, very important. So after this aortic ejection click, let me tell you, it is a systolic sound. Right, let me tell you, it's a systolic sound. And upon auscultation, right, upon auscultation, you also listen an ejection systolic murmur. Right, ejection systolic murmur. And this particular ejection systolic murmur, it is heard in the aortic area. Right, it is heard in the aortic area. And this ejection systolic murmur is also associated with thrill. And this ejection systolic murmur, it is of harsh quality. Right, it is of harsh quality, and this will radiate to the carotids. Right, this will radiate to the carotids. Okay, so that is about the ejection systolic murmur that you will have in patients with the aortic stenosis. Okay, so let me just show you the pulse of the aortic stenosis. See, this is the pulse of the aortic stenosis, that is called pulsus parvus et tardus. So you can observe that here, it's a slow rising pulse with there is a late peaking. Right, so that is what you will observe in patients with the aortic stenosis. Now in the auscultation, you have to remember one important phenomenon that is called as Gallaverdin phenomenon. That is very classical in patients with aortic stenosis. In some cases, only the high pitched component of the murmur are heard at the apex, and murmur may sound like mitral regurgitation. So the murmur of the aortic stenosis, right, which is heard in the aortic area, that will get conducted to the apex of the heart. Okay, so what is this Gallaverdin phenomenon? Gallaverdin phenomenon is the high pitched component right, high pitched component of the murmur it is heard at the apex of the heart. Okay, and this murmur may mimic, right, this murmur may mimic the murmur of the mitral regurgitation. and that is what is called as Gallaverdin phenomenon. Now the question is, how do you differentiate that from mitral regurgitation then? Let me tell you. So this murmur of Gallaverdin phenomenon, it does not radiate to axilla. Right? It does not radiate to axilla. Whereas the murmur of mitral regurgitation, this will radiate to the axilla. Right? The murmur of mitral regurgitation, this will radiate to axilla, and that is what is called as, that is how you will differentiate the Gallaverdin phenomenon from the murmur of mitral regurgitation. But both of them, Gallaverdin phenomenon is also heard at the apex, which is a systolic murmur. Mitral regurgitation murmur is also heard at the apex, that is also a systolic murmur. Okay. Now, after having discussed about the examination findings in patients with aortic stenosis, let me discuss how to assess the severity of aortic stenosis. So, let me discuss how to clinically assess the severity of the aortic stenosis. Okay. So, one of the very important general physical examination findings which can tell you that it is a severe aortic stenosis is narrow pulse pressure. Right, narrow pulse pressure. Okay. So, in case of severe aortic stenosis, right, what will happen to systolic blood pressure? The systolic blood pressure is very low, right, in patients with severe aortic stenosis. So, when the systolic blood pressure is very low, what will happen to the pulse pressure? Right, the pulse pressure will be reduced. Okay. So, narrower the pulse pressure, the more severe is the aortic stenosis. Okay. Next, the presence of the systolic thrill or the carotid thrill. Also tells you that the individual has severe aortic stenosis. Okay. Then followed by that, clinically, if patients with aortic stenosis, if they are symptomatic, aortic stenosis with left ventricular failure, right, aortic stenosis with left ventricular failure, that is also the one which will tell you that the individual is having severe aortic stenosis, right? And the auscultatory sounds, that is the presence of S3 and as well as S4. So when is that you will be able to listen S3 and S4? Only when the individual of aortic stenosis has developed the congestive heart failure. That is the point when you will listen the S3 and as well as the S4. Okay. Next, the another important point which will assess the severity is the echo. Right, another important point which will assess the severity is the echo. So, Doppler echo can quantitate the gradient across the aortic valve. So, the gradient across the aortic valve, right, the gradient across the aortic valve is also the one which will assess the severe aortic stenosis. Then followed by that, even your second heart sound. See, in an individual with aortic stenosis, right, that is in mild aortic stenosis. In mild aortic stenosis, you will have a normal split of the second heart sound. But whereas in case of moderate aortic stenosis, the split becomes narrowed. Why? Because of delayed A2. Right. So A2 will go near to your P2 because there is delayed emptying. So thereby what will happen to the closure? The closure of the aortic valve is also delayed. So thereby you will have a closely split second heart sound. Okay. Closely split second heart sound is seen in case of the moderate aortic stenosis. Whereas, where is that you will listen the reverse split? Reverse split of the second heart sound you will have that in severe aortic stenosis. So in severe aortic stenosis, you will have the reverse split of the second heart sound. That is, you will listen P2 and then followed by that A2. That is what you will have in severe aortic stenosis. Okay. Next, few more points to tell about the severe aortic stenosis is symptomatic aortic stenosis. You take any symptom, right? You take any symptom, right? Either the individual is having syncopal attack, or the individual having angina, or the individual is having dyspnea. So symptomatic patients, they have severe aortic stenosis, okay? And at the same time, please remember, if the patient is asymptomatic, it does not rule out the severe aortic stenosis, okay? Right, even asymptomatic severe aortic stenosis can also be there. And how can you diagnose that? That is by your two-dimensional echocardiography, okay? And another parameter which tells you about the severe aortic stenosis is the peak of ejection systolic murmur, the more severe is the aortic stenosis, okay? So the peak of the peak of ejection systolic murmur more severe is the aortic stenosis, okay? Next, the another important point, we can also assess the severity based on the ECG also. So what does the ECG shows? The ECG, it will show you the presence of the STT changes, right? STT changes in ECG also favor the severe aortic stenosis, okay? So these are all the parameters which will assess the severity, right? So narrower the pulse pressure, more severe is aortic stenosis. Then the presence of the carotid thrill. Next, the auscultation S3 and S4, and aortic stenosis with left ventricular failure. 2D echo showing increased gradient across the left ventricle and as well as the aorta. Presence of reverse split S2, then followed by that any symptom in aortic stenosis, it is a severe aortic stenosis. Then late the peak of ejection systolic murmur, the more severe is the aortic stenosis. And finally the ECG changes showing the STT changes, okay? Now let me just show you a question. A 75-year-old man is brought to the casualty with sudden syncopal episodes while playing with his grandchildren, right? He is currently alert and describe occasional substernal heaviness and shortness of breath. His lungs have bibasilar rales and blood pressure is 120 by 80 millimeters of mercury. Which is the classical finding expected in this particular patient? It's a harsh ejection systolic murmur with soft S2, harsh ejection systolic murmur with wide split S2, harsh hollow systolic murmur with soft S2, harsh pansystolic murmur with loud S2. So the ejection systolic murmur of aortic stenosis, it will be very harsh, right? It's a harsh ejection systolic murmur with soft S2, that is A2 will be soft, right? The A2 will be soft. That is what you will find in patients with the aortic stenosis. Then coming to the complication that can be seen in aortic stenosis. See, in patients with aortic stenosis, there is increased tendency of the sudden cardiac death, right? There is increased tendency of sudden cardiac death, okay? So symptomatic severe aortic stenosis is associated with high risk of sudden cardiac death. And this particular sudden cardiac death, it has been observed in 0 to 5% of adults with asymptomatic aortic stenosis, okay? 0 to 5% of adults with asymptomatic aortic stenosis, right? And sudden cardiac death can also be seen in 8 to 34% of adults with symptomatic aortic stenosis, right? With symptomatic aortic stenosis, okay? And what is the mechanism for the development of the sudden cardiac death? Let me tell you. Sudden cardiac death in aortic stenosis, what are the potential causes, right? The potential causes, they include abnormal basal gyrus reflex with hypotension, right? Abnormal basal gyrus reflex with hypotension. What is basal gyrus reflex? I'll explain you. Okay, and second important cause will be the malignant ventricular arrhythmias. Right? So these are the potential causes for sudden cardiac death in patients with the aortic stenosis. Now coming to your basal-gyrus reflex. So basal-gyrus reflex, it is also called as the cardiopulmonary reflex. So what happens is there will be a triggering factor, and that particular triggering factor will stimulate the cardiopulmonary chemoreceptors and cardiopulmonary mechanoreceptors of the left ventricular wall. Okay, so here what is happening to the left ventricle? The left ventricular wall, it is hypertrophied, and that too it's a concentric hypertrophy, and that will stimulate the chemoreceptors and as well as the mechanoreceptors. And because of the stimulation of these receptors, there will be passage of the impulse through an unmyelinated vagal afferent type C fibers. Okay, so the vagal afferent, they take the impulse from the chemoreceptors and mechanoreceptors, and this vagus will inhibit the vasomotor center, right? Will inhibit the medullary vasomotor center. That means sympathetic outflow will be reduced. Right? Sympathetic outflow will be reduced, and there will be increase in the parasympathetic tone. And because of this, there will be a triad of bradycardia, because there is increase in parasympathetic tone, there will be hypotension, and there will be peripheral vasodilatation. All these will contribute to the sudden cardiac death within the individual. So please remember, stimulation of the basal-gyrus reflex is one of the cause for sudden cardiac death in patients with aortic stenosis. So what happens here? The hypertrophied left ventricle, right, there will be stimulation of the chemoreceptors and mechanoreceptors in the left ventricular wall, and that will cause the stimulation of the vagal afferent type C fibers, which will cause the inhibition of medullary vasomotor center, and there is increase in the parasympathetic tone, and that will lead to a triad of bradycardia, hypotension, and peripheral vasodilatation. Okay, now, and please remember, how can you reduce the risk of sudden cardiac death? The risk of sudden cardiac death is reduced by the valve replacement. So prompt valve replacement is generally recommended for symptomatic aortic stenosis. Okay, that is how you can reduce the incidence of the sudden cardiac death. Now coming to the diagnosis. So ECG will often show, see, there are various methods of diagnosing the aortic stenosis. Definitely the first line investigation will be the 2D echo, that is two-dimensional echocardiography will be the first line investigation. Then followed by that, the other investigations what we have is the ECG and as well as the chest X-ray, and the definitive diagnosis is by cardiac catheterization. Okay, so let me discuss all these investigations in patients with aortic stenosis. So what does the ECG show? ECG will often show the presence of the left ventricular hypertrophy. Now what will be that features of left ventricular hypertrophy in the ECG? Let me explain you. See, we have a criteria, and that particular criteria, it is called Sokolov-Lyon criteria. Now according to your Sokolov-Lyon criteria, the depth of S wave in V1 plus the height of R wave in V6, it should be more than 35 mm. Right, it should be more than 35 mm, and that is what is called as the Sokolov-Lyon criteria. So if the amplitude is more than 35 mm, that is suggestive of left ventricular hypertrophy. Right, that is suggestive of left ventricular hypertrophy. So you see here, how much is the depth of the S wave in V1? It is 16 mm. Right, and how much is the amplitude of the R wave in case of V6? That is 32 mm. So if you add both of them, 16 plus 32, that will be around 48 mm. So that is definitely more than your 35 mm. So that will satisfy your Sokolov-Lyon criteria of the aortic stenosis. Next, then followed by that, the chest X-ray. See, what does the chest X-ray shows? For example, if the etiology causing aortic stenosis, if it is due to calcification and degeneration of the aortic valve, you will observe the calcified aortic valve. Right, you will observe the presence of the calcified aortic valve. And not only that, there will be also cardiomegaly, but that cardiomegaly will be seen only when there is development of eccentric hypertrophy, but not in the concentric hypertrophy stage. Okay, but do you have eccentric hypertrophy in aortic stenosis? It is very rare, very, very rare. And the another important chest X-ray finding is pulmonary congestion. So why is this pulmonary congestion? And that is because of the development of the congestive heart failure. There can be development of the pulmonary congestion. And not only that, you take the ascending aorta, you take the contour of the ascending aorta. Right, if you take the contour of the ascending aorta, right, the contour of the ascending aorta, it will be more bulged. Right, the contour of the ascending aorta, it is more bulged. Okay, so it is like supravalvular, that means above the valve there is bulging of the aorta. Okay, so that is what is nothing but the contour of the ascending aorta is being bulged. Next, now after having discussed about the X-ray, the next important investigation is the echocardiography. So what does the echocardiography you can make out? That will show you the presence of thick aortic valve leaflets. Right, there will be thick aortic valve leaflets. Okay, and this thick aortic valve leaflets will cause decreased excursion, that is decreased movement of the valve. Right, decreased excursion, and there is also development of left ventricular hypertrophy. And not only that, in the 2D echo, see, apart from the valve area, what all we check in the 2D echo in patients with aortic stenosis? See, we measure the aortic jet velocity, we measure the gradient across the valve and as well as the valve area. Now, what is a normal valve area? That is around 3 to 4 centimeters square. And in case of mild aortic stenosis, valve area is 1 to 1.5 centimeters square. It is around 1.5 to 2 centimeters square. Whereas in moderate aortic stenosis, it is around 1 to 1.5 centimeters square. Whereas in severe aortic stenosis, the valve area will be less than 1 centimeter square. Okay. Now, whereas you take the gradient, the normal gradient between the left ventricle and aorta, it will be less than 5 millimeters of mercury. Whereas in mild aortic stenosis, the gradient will be 25 millimeters of mercury. Whereas in moderate aortic stenosis, the gradient is 25 to 40 millimeters of mercury. Whereas in case of severe aortic stenosis, the gradient is more than 40 millimeters of mercury. So that is what is the gradient in mild, moderate, severe, and that is how there will be assessment of the severity of aortic stenosis. And you take the aortic jet velocity. The aortic jet velocity in a normal individual will be less than 2 meters per second. Whereas in mild aortic stenosis, the aortic jet velocity, it is around 2 to 3 meters per second. Whereas in moderate aortic stenosis, the aortic jet velocity is around 3 to 4 meters per second. Whereas in severe aortic stenosis, the aortic jet velocity is more than 4 meters per second. Okay. So this is how you will assess the severity of the aortic stenosis. That is based on the valve area, mean gradient, and as well as the aortic jet velocity. Now, apart from this, we have one clinical entity in aortic stenosis called as low gradient severe aortic stenosis with low left ventricular ejection fraction. So this is called as low flow, low gradient aortic stenosis. Now, what do you mean by this? See, in some patients with an aortic valve area less than 1 centimeter square with a low cardiac output and stroke volume, the mean gradient may be less than 40 millimeters of mercury. So, what I mean by this is the valve area is less than 1 centimeter square, right? Valve area is less than 1 centimeter square. When valve area is less than 1 centimeter square, what should happen to the gradient? The gradient should be more than 40 millimeters of mercury. But in these individuals with valve area less than 1 centimeter square, the gradient is, right, the gradient is less than 40 millimeters of mercury. And this is what is called as low flow, low gradient aortic stenosis. Right. Now, where will you come across this particular scenario? This can occur when there is left ventricular systolic function is poor. Okay. So, you will come across this particular scenario whenever there is left ventricular dysfunction. Right. So, when there is left ventricular dysfunction, then you will have this low flow, low gradient aortic stenosis. Why? Because whenever there is left ventricular dysfunction, what will happen to the pressure rise within the left ventricle? The pressure rise within the left ventricle will be decreased. So, when the pressure rise within the left ventricle is decreased, what will happen to the gradient between the left ventricle and aorta? That will be decreased. Okay, so that is called as low flow. Why is it low flow? Because the valve area is less than 1 centimeter square. Low gradient. Why it is low gradient? That is because of the left ventricular dysfunction. So this is called as low flow, low gradient aortic stenosis. Right? So now how much will be that low flow? When you see gradient, you said low gradient less than 40 millimeters of mercury. When you are using the word low flow, that is low output. Low flow in these situations is defined by an echocardiographic stroke volume index of less than 35 ml per minute per meter square. Okay, so how much will be your stroke volume index? Right, stroke volume index will be less than 35 ml per minute per meter square. So that will be the stroke volume index in patients with the low flow, low gradient aortic stenosis, right? So if you see the prognosis in these patients with aortic stenosis of low flow, low gradient, the prognosis in these patients is worse than in patients with the traditional high gradient, okay? So the prognosis is worse than in patients with the traditional high gradient aortic stenosis. Okay. Now, after having discussed about this low flow, low gradient, let me just discuss the 2D echo. You take in case of the high gradient, right? So, in case of patients with severe aortic stenosis, what is that I have discussed about the aortic jet velocity? The aortic jet velocity, it is more than 4 meters per second. Right, it is more than 4 meters per second. That is the aortic jet velocity. And how much will be the gradient? The gradient is more than 40 millimeters of mercury. Okay, that is what you mean by the word high gradient. Then what do you mean by the word super severe aortic stenosis? In case of super severe aortic stenosis, the aortic jet velocity will be more than 5 meters per second. Right, it will be more than 5 meters per second. That will be the aortic jet velocity. And how much will be the gradient in case of super severe aortic stenosis? The gradient will be more than 55 millimeters of mercury. So that will be the gradient in case of super severe aortic stenosis. Okay. Next, then coming to your low gradient. See, in case of low gradient, what did I tell you? There will be left ventricular dysfunction. So the ejection fraction will be less than 50%. Right, ejection fraction will be less than 50%. Okay, and at the same time the low flow. And how is that you will be able to make out that there is a low flow? That is by the stroke volume index. So stroke volume index stroke volume index, it is less than 35 ml per minute per meter square. Okay, so that is what is your stroke volume index, right? Now, so this is about the story related to the low flow, low gradient aortic stenosis, where the individual has the worst prognosis, And another important investigation is the NT-proBNP, right? NT-proBNP. See, some authors have suggested the use of the brain natriuretic peptide, right? So this NT-proBNP will provide additional prognostic data. Right, will provide an additional the prognostic data in the setting of poor left ventricular function and aortic stenosis. So this NT-proBNP is mainly used in individuals with poor left ventricular function. Okay, next, when the BNP value, if it is greater than 550 picograms per ml, right, when the BNP value, if it is greater than 550 picograms per ml, that has been associated with poor outcome in these patients regardless of the results of the dobutamine testing. Okay, so this is associated with poor outcome. Next, then followed by that, you take the guidelines. European valve guidelines suggest the intervention when NT-proBNP is 3 times the normal. Okay, the intervention has to be done when the NT-proBNP value is 3 times the normal. That is the point when the intervention has to be done. So this is according to the European valve guidelines. Now, I have to discuss one important point regarding this low flow, low gradient aortic stenosis, that is dobutamine stress testing. Let me explain you what is this. Now, in case of low flow, severe aortic stenosis with low gradient, what did I tell you? Left ventricular ejection fraction is less than 50%. Now, you have to make out, see, you need to know whether that low gradient is due to left ventricular dysfunction or is it because of the aortic stenosis per se. Let me discuss how will you differentiate. If low flow severe aortic stenosis is present in the face of low ventricular ejection fraction, and how much is that? That is less than 50%. Provocative testing with dobutamine or nitroprusside is sometimes warranted. Mainly what we use is dobutamine. We don't use nitroprusside. Mainly what we use is dobutamine. See, is sometimes warranted to increase the stroke volume to discover if the mean aortic valve gradient of less than 40 millimeters of mercury can be demonstrated without increase in the aortic valve area. So the purpose of doing this dobutamine stress testing, what is this dobutamine stress testing? When we are doing the 2D echo, we inject the dobutamine into the individual and then we will measure the gradient, right? We will measure the gradient. And what is the purpose of this dobutamine stress testing? That is mainly to discover if the mean gradient of at least 40 millimeters of mercury can be demonstrated without increase in the aortic valve area. That means when you are doing this dobutamine stress testing, that will increase the myocardial contractility and that should increase the gradient. That will happen in an individual with normal left ventricular ejection fraction. But here there is low ejection fraction. At least you should be able to demonstrate a gradient of 40 millimeters of mercury with the help of dobutamine stress testing. So basically dobutamine stress testing is done only in individuals with low flow, low gradient aortic stenosis. Okay. Now, after having discussed about the diagnosis, and next important thing is the definitive diagnosis, that is the cardiac catheterization. So cardiac catheterization, it is the definitive diagnosis. See, it mostly provides an assessment of the hemodynamic consequence of the aortic stenosis, and it will also provide the anatomy of the coronary arteries. So, this will provide this will provide the anatomy of the coronary arteries, and not only that, this will also help you in assessment of hemodynamic consequence of the aortic stenosis. And this cardiac catheterization, it is very important when there is discrepancy between the symptoms and echocardiography. Right, when there is discrepancy between the symptoms and aortic stenosis, that is the point when we do this cardiac catheterization, right? So this is about the investigations in patients with the aortic stenosis. Now next let me discuss about the treatment of the aortic stenosis. So all those individuals who are symptomatic, they require the valve intervention. So valve intervention right, so this is mandatory right, so this is mandatory in all those individuals who are having symptomatic aortic stenosis, right? So this is a very important point that you have to remember. All those individuals who are having symptoms in patients with aortic stenosis, that is either syncopal attack or angina or congestive heart failure, they require the valve intervention, okay? And there are also times when asymptomatic aortic stenosis should undergo intervention. I'll tell you. So there are certain conditions, right? There are certain conditions where asymptomatic patients, they require valve interventions. Okay, next. Followed by that, you take the medical management. Medical therapy to reduce the progression of the disease, this has not been effective until date. Okay, so medical management. This has found to be not effective. Right, this has found to be not effective to reduce the progression of the disease. Now let me discuss asymptomatic patients. That means which clinical scenarios of asymptomatic patients with severe aortic stenosis, they require the intervention. Let me discuss that point. So you see here, asymptomatic patients with severe aortic stenosis, that is, so when do we use the terminology called severe aortic stenosis? That is when the valve area is less than 1 centimeter square. Right, valve area is less than 1 centimeter square. They should generally undergo intervention according to the following guidelines. Number 1, an individual with asymptomatic severe aortic stenosis and they are undergoing other cardiac surgery. Okay, so they are undergoing other cardiac surgery. And what would be that other cardiac surgery? The other cardiac surgery, for example, the individual undergoing CABG, that is coronary artery bypass graft. Okay, and an individual with asymptomatic severe aortic stenosis where there is evidence for a reduced left ventricular ejection fraction. Okay, where there is an evidence for reduced left ventricular ejection fraction. And how much should be that left ventricular ejection fraction? That should be less than 50%. Right? That should be less than 50%. Okay. Next, the other important point is when the mean gradient exceeds 55 millimeters of mercury. Okay. So when the mean gradient, in the sense the gradient between the left ventricle and aorta. So when the mean gradient exceeds 55 millimeters of mercury, even though the individual is asymptomatic, they have to undergo the aortic valve intervention. So either when the mean gradient is more than 55 millimeters of mercury, or the peak velocity the peak velocity greater than 5 meters per second. Okay, so these are some of the scenarios with asymptomatic patients with severe aortic stenosis where they have to undergo the aortic valve intervention. And some more indications in asymptomatic patients. For suppose these patients, when there is failure of blood pressure to rise more than 20 millimeters of mercury with exercise, right? When there is failure to rise the blood pressure more than 20 millimeters of mercury with exercise. Okay, so that is another indication in asymptomatic severe aortic stenosis where they have to undergo the aortic valve intervention. And next thing is when there is severe valvular calcium. Right, when there is severe valvular calcium, that is also an indication for the aortic valve intervention in asymptomatic patients with severe aortic stenosis. And the last one is when there is evidence of a rapid increase in the peak aortic gradient. Okay, when there is evidence of rapid increase in aortic valve gradient. So what do you mean by this rapid increase in the peak aortic gradient? That should be, right, that increase whatever is there, it should be more than 0.3 meters per second per year. Okay, so that is what you mean by the word rapid increase in the peak aortic gradient, and how much it should be? More than 0.3 meters per second per year, right? Now, so let me just summarize according to a recent updated guidelines, what are the indications for intervention. So whatever the interventions or whatever the indications I have discussed is in asymptomatic severe aortic stenosis. Now we have the guidelines, right? So we have 2017 updated American Heart Association or American Clinical Cardiology guidelines for surgical indication in aortic stenosis. First and foremost, right, COR stands for class of recommendation, right? LOE stands for level of evidence. Okay, so you take the class of recommendation. Class 1, these are all whatever I am just showing you is class 1 recommendations. That means if this scenario is there, definitely the individual has to undergo, right, the surgical intervention across the aortic valve. That is, aortic valve replacement is indicated in symptomatic patients with severe aortic stenosis. Right, in symptomatic patients with severe aortic stenosis. Number 2, aortic valve replacement is recommended in asymptomatic patients with severe aortic stenosis and left ventricular ejection fraction less than 50%, right? Even though the individual is having asymptomatic severe aortic stenosis, ejection fraction should be less than 50%. And third, AVR is indicated for patients with severe aortic stenosis when undergoing other cardiac surgery. This already just now we have discussed. Next, AVR is indicated for patients with severe aortic stenosis where the aortic velocity is more than 5 meters per second and there is low surgical risk, right? So the gradient or the velocity across the aortic valve more than 5 meters per second with severe aortic stenosis and low surgical risk. Next, TAVR or SAVR. TAVR stands for transcatheter aortic valve replacement. SAVR stands for surgical aortic valve replacement. They may be considered in high risk patients after evaluation by a heart team. That is also the class of recommendation is class 1. And surgical aortic valve replacement is recommended for symptomatic patients with severe aortic stenosis and asymptomatic who meet an indication for aortic valve replacement when surgical risk is low or intermediate. So severe aortic stenosis, symptomatic severe aortic stenosis. So they have to undergo the surgical aortic valve replacement. But surgical aortic valve replacement has to be done only when the individual has a low or intermediate surgical risk, right? Low or intermediate surgical risk. And one more class of recommendation is, class of recommendation 1 is TAVR or SAVR is recommended for symptomatic patients with severe aortic stenosis and high risk for surgical aortic valve replacement depending upon the patient's specific risks, values and as well as the preferences. And one more class of recommendation 1 is TAVR is recommended for symptomatic patients with severe aortic stenosis and prohibitive surgical risk who have a post-TAVR survival of more than 12 months. So whether to do TAVR, that is transcatheter aortic valve replacement, or SAVR, that is surgical aortic valve replacement, right? I'll just summarize. And what is this TAVR and what is this SAVR? Also I will discuss in detail. So this class of recommendation 1, you have to remember because these will be asked as a multiple choice questions to you, right? Now let me take up the TAVR versus SAVR. Okay, so TAVR is what? That is transcatheter aortic valve replacement. So transcatheter aortic valve replacement is that we don't cut open the chest for doing the aortic valve repair or the aortic valve replacement. In case of TAVR, actually there are many approaches by which you can reach to the aortic valve. But the most commonly used approach is the femoral artery approach. Right? The most commonly used approach is the femoral artery approach. So through the femoral artery, the aortic valve is being passed and we reach up to the level of the aorta and there the valve is placed and then the catheter is removed through the femoral artery. That will be your TAVR. Whereas surgical aortic valve replacement is what? Like we need to cut open the chest, reach the aortic valve, take out the calcified or degenerated aortic valve and we keep a prosthetic valve. That will be your surgical aortic valve replacement. Now, in which group of individuals TAVR has to be done and in which group of individuals SAVR has to be done? So, any individual with severe aortic stenosis who is symptomatic and having low surgical risk, they have to undergo surgical aortic valve replacement. But the individual is having intermediate surgical risk, then either SAVR, which is more preferable than compared to that of your TAVR. Whereas in those individuals with high surgical risk, right, again the same, either SAVR or TAVR, both of them class 1 recommendation. And if there is prohibitive surgical risk and in those individuals surgical aortic valve replacement should not be done, it should be only TAVR, that is transcatheter aortic valve replacement. Now, let me discuss what will be the devices which are used in case of TAVR and as well as the SAVR. So, if you take the TAVR devices, right, see, in the United States, the FDA has granted approval for 2 devices. One is the Edwards-Sapien valve, right, one is the Edwards-Sapien valve and the other important valve is Medtronic core valve. Right, Medtronic core valve. So these are the 2 devices which has been approved by FDA in the United States. And these devices are fundamentally stents with tri-leaflet bioprosthetic valve. So both of them, they are right? They are stents with a tri-leaflet right, stents with a tri-leaflet bioprosthetic valve, right, which is constructed within them, right? And I said you there are variety of implantation approaches for this, the TAVR devices, but most valves are placed via the femoral artery approach. Now, if you take the little explanation about these valves, you take this Edwards sapien valve. Edwards sapien valve, it is a balloon expandable valvular stent. Right, it is a balloon expandable valvular stent. That is what is your Edwards sapien valve. Whereas you take the Medtronic core valve, right? Medtronic core valve, it is a valvular stent that self expands when pushed out of the catheter sheath, right? So this is a right, that is a valvular stent that self expands right, that self expands when pushed out of the catheter sheath. Okay, so that is about your Medtronic core valve. So Edwards sapien valve, it is balloon expandable valvular stent, while the core valve is a valvular stent that self expands when pushed out of the catheter sheath. Now, right, so you see these are the examples of your TAVR, that is transcatheter aortic valve replacement, right? So what is this? This is your Medtronic core valve. So in Medtronic core valve, like what is that we have discussed? In case of Medtronic core valve, the valvular stent that self expands when pushed out of the catheter. Okay, right. And this particular valve, it is a balloon expandable valve. So whatever you are seeing here, it is a right, it is a balloon expandable valve. Okay, so this is an Edwards sapien valve, right? This is an Edwards sapien valve. Okay, and this is also your TAVR device, transcatheter aortic valve replacement device. Now, so one of the method of the intervention of severe aortic stenosis is by your TAVR, that is transcatheter aortic valve replacement. Then you take surgical aortic valve replacement. Surgical aortic valve replacement is done by two methods. One is mechanical, the other one is bioprosthetic aortic valve replacement. So the use of mechanical versus bioprosthetic valve aortic valve replacement has changed over time. This bioprosthetic valve is acceptable for patients at any age for whom anticoagulation is contraindicated. Okay, so this has to be placed in individuals in whom anticoagulation is contraindicated. Okay, so and in which group of individuals we use this bioprosthetic valves is, it is preferred in patients over the age of 70 years. So more than or equal to 70 years, the preferred valve is the bioprosthetic valve, because in those individuals the anticoagulant therapy, right, it is not indicated much because there is chance of the bleeding tendencies in these individuals. Now you take the mechanical valve, right? You take the mechanical valve. See, an aortic mechanical valve should be used in patients younger than 50 years of age. Right, younger than 50 years of age who can take warfarin, right? So in those individuals who can take warfarin in age less than 50 years, we use this particular mechanical valve, okay? And this recommendation is a decrease from age 60 in the recent updated guidelines. Actually, in the previous guidelines, it was said that the mechanical valve should be used in age less than 60 years. But the present guidelines says that these mechanical valves are used in individuals less than 50 years. Okay, then see, more than or equal to 70 years, that is bioprosthetic valve, and less than 50 years, that is your mechanical valve. Then what about the age group between 50 to 70 years? Right, what about in age group between 50 to 70 years? See, either type of valve is acceptable between the ages of 50 and 70 years depending on patient's preference and any issue with warfarin usage. Okay, so any valve is acceptable. Right, any valve is acceptable between the age group of 50 to 70 years. Then coming to the anticoagulation, you see these patients with mechanical valve, there is risk of thrombosis, so they require the anticoagulation. Now let me discuss about the anticoagulation in individuals who have undergone mechanical aortic valve replacement. So anticoagulation is required with the use of mechanical aortic valve, and the INR that has to be maintained should be in between 2 and 3 for bileaflet valves. Okay, so for bileaflet valves, the INR that has to be maintained when the individual is on anticoagulation should be 2 to 3, right? Should be in between 2 and 3. In general, mechanical aortic valves are less subject to thrombosis than mechanical mitral valves. Okay, so mechanical aortic valve right, these individuals, they have less risk of thrombosis. Then compared to that of mechanical mitral valve. And these patients with mechanical aortic valve, they do not need bridging with anticoagulation unless there are other thromboembolic risk factors. Okay, so these patients with mechanical aortic valve, there is no bridging of the anticoagulation. Right, there is no requirement of bridging with anticoagulation unless there are other thromboembolic risk factors. Okay, and apart from this anticoagulation, low dose aspirin is also recommended as well. See, this low dose aspirin, which is an antiplatelet drug, right, which is an antiplatelet drug, is recommended as well as a prophylactic agent to prevent the thrombosis over the mechanical aortic valve. So this is about the treatment of the aortic stenosis. So please remember, any individual who is symptomatic, definitely they require intervention, and any individual who is asymptomatic, depending upon certain clinical scenarios, they require the intervention. right? What are those? Like asymptomatic individuals with left ventricular ejection fraction less than 50%. Asymptomatic severe aortic stenosis undergoing other cardiac surgeries like CABG. Asymptomatic severe aortic stenosis where the mean gradient is more than 55 millimeters of mercury. Asymptomatic severe aortic stenosis where there is failure of blood pressure to rise more than 20 millimeters of mercury with exercise. Asymptomatic severe aortic stenosis where there is severe valvular calcium, and asymptomatic severe aortic stenosis where there is evidence of rapid increase in peak aortic gradient more than 0.3 meters per second per year. So this is about the treatment. Now let me just summarize the entire topic of the aortic stenosis. So these are the summary points. If you take the essentials of the diagnosis, that is summary of aortic stenosis, congenital bicuspid aortic valve. Usually, it is the most common cause of aortic stenosis in individuals less than 60 years. Whereas, in elderly individuals, the most common cause of aortic stenosis is degenerative or calcific aortic stenosis. And visual observation of immobile aortic valve plus valve area of less than 1 centimeter square define the severe aortic stenosis or severe disease, right? Next point, echocardiography or Doppler is the one which is diagnostic for aortic stenosis, and surgery typically indicated for symptomatic aortic stenosis, and TAVR is approved for patients with calcific aortic stenosis. And intervention appropriate even in asymptomatic patients with super severe aortic stenosis or when undergoing heart surgery for other reasons. And next important, brain natriuretic peptide is a marker of early left ventricular myocardial failure, and high levels suggest poor prognosis, right? So these patients with aortic stenosis, they initially develop diastolic dysfunction and then systolic dysfunction. So there will be a myocardial dysfunction, and for that BNP, brain natriuretic peptide, is a marker of early left ventricular myocardial failure, and high levels, they suggest the poor prognosis. So this will be the essentials of the diagnosis. So having discussed about the entire topic of aortic stenosis, let me discuss some important multiple choice questions on the topic of the aortic stenosis. So if you see this question first, a patient recovered from right hemiparesis, and on examination, patient was found to have aortic valve lesion and is in sinus rhythm. What will you do to prevent the further stroke? Antiplatelet only, anticoagulant only, both antiplatelet and anticoagulant, low molecular weight heparin subcutaneously. Now, see, there is certain data and as well as guidelines in which group of individuals you don't require any therapy, in which group of individuals you require antiplatelet like aspirin, and in which group of individuals you require the anticoagulants. See, he is a patient with aortic valve lesion. The guidelines are slightly different from the mitral valve disease to that of the aortic valve disease. So if you see in case of the rheumatic mitral valve disease with atrial fibrillation and past history of the thrombotic strokes or past history of, or like if the left atrial diameter is more than 55 millimeter, they require vitamin K antagonist, that is warfarin. And if there is left atrial appendage clot despite INR 2 to 3, these patients, they require vitamin K antagonist plus aspirin. And with otherwise cryptogenic stroke or transient ischemic attack, they require the aspirin. And patients with rheumatic mitral valve disease with atrial fibrillation, they require the vitamin K antagonist. So this is about the story related to your rheumatic mitral valve disease. But what about the aortic valve pathology or aortic valve calcification? That is what is actually our question. If the individual is asymptomatic aortic valve calcification, these patients, they don't require either antiplatelet or they don't require even the anticoagulant. Otherwise, the individual with aortic valve calcification with cryptogenic stroke or transient ischemic attack, they require this particular aspirin. They require this aspirin. So going back to the question, a patient recovered from right hemiparesis, in the sense had a cryptogenic stroke or a transient ischemic attack. Either of it would be, right? The history is not very clear. and on examination patient was found to have the aortic valve lesion and he is in sinus rhythm, no atrial fibrillation. So what is that you will give to prevent the further stroke? That is the antiplatelet only, right? Now, after having discussed about which group of individuals we give the antiplatelet or anticoagulant, you see the next question. 18-year-old boy is brought to your hospital with loss of consciousness. He regains consciousness in the emergency department and GCS on admission is 12/15. CNS examination is normal and auscultation reveals a narrow split second heart sound and clear lungs. ECG was done and what is the diagnosis? Left ventricular outflow tract obstruction, right ventricular outflow tract obstruction, atrial fibrillation with cerebral embolism, subarachnoid hemorrhage with T-wave inversion. So, the clinical points, if you see, loss of consciousness, that is a syncopal attack, a narrow split S2 and clear lungs, and ECG has been done. So even ECG, it is suggestive of left ventricular hypertrophy, and there are also STT changes, right? You can see that here. This is your T-wave inversions. STT changes in the form of the LV strain, right? In the form of the LV strain. So what is this suggestive of? This is suggestive of left ventricular outflow tract obstruction. Why are you saying that? Because the auscultation is showing a narrow split S2. Where can you have this? You can have this in patients with the aortic stenosis. And in patients with aortic stenosis, there can be also loss of consciousness or there can be syncopal attack. And ECG shows the left ventricular hypertrophy. Okay, next. You see the next question. 63-year-old man presents with a triad of angina, syncope and congestive heart failure. Which of the valvular heart lesion can be suspected? Mitral stenosis, tricuspid regurgitation, aortic stenosis and aortic regurgitation. So the answer in this question is the aortic stenosis. Why? Because you take this SAD, that is syncopal attack, angina and as well as dyspnea secondary to congestive heart failure. This particular triad is suggestive of the aortic stenosis. Right? Next question. In severe aortic stenosis, what is the true finding? Late systolic ejection click, heaving with outward apex, ST segment deviation in the ECG and the presence of loud S2. So, late systolic ejection click is a wrong statement. In patients with the aortic stenosis, you have the click in the early part of the systole. Okay? And heaving with the outward apex. Let me tell you, in patients with aortic stenosis, either you take mild or you take moderate aortic stenosis, they will have the heaving type of the apical impulse or heaving apex beat. And loud S2 is not a feature in case of severe aortic stenosis. So you will have a soft A2. Right? You will have a soft A2 in severe aortic stenosis. Then what about the ECG finding? Yes. In severe aortic stenosis, the ST segment deviation in ECG is suggestive of the severe aortic stenosis. Next question. Sudden death. Now actually in the theory part, like I have discussed all the points which will favor the severe aortic stenosis. Right? What is that? You start from the pulse. Right? Pulsus parvus et tardus, that is slow raising pulse with late peaking. That is suggestive of severe aortic stenosis. Next, the presence of systolic hypotension, that is also suggestive of severe aortic stenosis. Number 3, presence of narrow pulse pressure. Narrower is the pulse pressure, more severe is your aortic stenosis. Then followed by that on auscultation presence of S3 and S4. Then presence of the narrow split S2 or reverse split S2, that is suggestive of severe aortic stenosis. Next, sudden death can be seen in aortic stenosis, mitral stenosis, MR and then the TR. The answer is the aortic stenosis. Now what is the cause of sudden cardiac death in patients with aortic stenosis? That is due to number 1, right? That is due to number 1, activation of basal-gyrus reflex, right? Number 2, activation of malignant ventricular arrhythmias. Okay, so this will be the cause for sudden cardiac death in patients with the aortic stenosis. Next, the next important question is the most common complication of the subvalvular aortic stenosis. The aortic regurgitation, mitral regurgitation, tricuspid and pulmonary regurgitation. So, the most common complication of subvalvular aortic stenosis will be the aortic regurgitation. Next question. Which of the following physical sign is seen in patients with severe aortic stenosis? Opening snap, diastolic rumble, hollow systolic murmur, delayed peak of the systolic murmur. So let me tell you, opening snap, it is present either in patients with mitral stenosis or tricuspid stenosis. Diastolic rumble, right, it is seen in patients with the mitral stenosis. The hollow systolic murmur, it is present in VSD, tricuspid regurgitation and mitral regurgitation. Then delayed peak of the systolic murmur is the one which is suggestive of the severe aortic stenosis. Right? Next question. A 50-year-old man with aortic stenosis is doing exercise for 11 minutes according to the Bruce protocol. Exercise stopped due to fatigue. Regional pressure gradient is 60 millimeters of mercury between the two sides of the aorta. What is the best management? The angiogram, aortic valve replacement, aortic balloon to prevent further derangement, observation. So these patients, he is like asymptomatic severe aortic stenosis before doing the treadmill test, but upon exercise the gradient is increased to 60. So these patients, they require the aortic valve replacement. So asymptomatic severe aortic stenosis also they require the aortic valve replacement in certain clinical scenarios which I have already discussed in the treatment part. Next, all of the following clinical findings are seen in patients with isolated aortic stenosis except left ventricular impulse is displaced laterally, pulsus bisvariance is the hallmark finding, systolic blood pressure is normal in early stage of the disease, the presence of the carotid thrill. So the question is except which of the following is not seen. So in case of the isolated aortic stenosis, the carotid thrill, it is present. Systolic blood pressure is normal in early stages of the disease. Left ventricular impulse displaced laterally, it is slightly a question mark, and pulsus bisvariance is the hallmark finding is a wrong statement. So what is that pulse you will have in patients with isolated aortic stenosis? That is pulsus parvus et tardus, right? The characteristic pulse of aortic stenosis is pulsus parvus et tardus. And in aortic stenosis, there will be left ventricular hypertrophy, right? And because of left ventricular hypertrophy, there will be heaving type of apical impulse. But if the aortic stenosis is so severe that the individual also develops the right heart failure, and if there is right ventricular dilatation because of the backflow, there can be movement of the apical impulse laterally, but otherwise no. It will be present in the fifth left intercostal space medial to the midclavicular line, but only in the clinical scenario where there is right heart involvement secondary to your aortic stenosis. That is the point when the apex beat may shift laterally. And where do you see this pulsus bisvariance? Pulsus bisvariance, it is seen in patients with the hypertrophic obstructive cardiomyopathy, right? It is seen in patients with severe aortic regurgitation, and it is seen in patients with AS with AR. But what is the question asked? Isolated aortic stenosis, right? Isolated aortic stenosis. Next question. Murmur heard in the aortic stenosis. Right second intercostal space, low pitched murmur. Murmur is heard at the apex, it's a low pitched murmur. Left sternal edge, low pitched murmur. Pansystolic murmur, high pitched murmur. Okay, so the murmur of the aortic stenosis, it is heard in the right second intercostal space and it is a low pitched murmur, right? It is not a pansystolic murmur. It is the ejection systolic murmur, right? So the murmur of aortic stenosis, it is a low to medium pitch. Right? Low to medium pitch, and it is harsh or rasping in character. right? It is rasping or harsh in character. Okay, so that will be the murmur of the aortic stenosis. So these are some of the very important questions related to the topic of the aortic stenosis. Thank you very much.